Good morning, everybody. I'm Howard Chansky, the chair of the Department of Orthopedics and Sports Medicine. Welcome to our last grand rounds of this academic year. And we're fortunate to have Dr. Firoozabadi, who's an associate professor at Harborview and chief of the Pelvic and Acetabular Service, as well as Steve Bain, who's a research associate professor, PhD in our department, and Avrey Novak, who's a third-year resident. And they're going to be discussing posterior wall acetabular fracture management and outcomes. And prior to that, I have a couple of brief announcements. First, the kudos. First one is from Children's, and it's for Dr. Pooja Prabhakar. And it's thanking Pooja for rescuing the ED when they had about 25 to 30 patients in the waiting room. And the fact that she was responding to rapid fire pages really efficiently really helped the ED that night. Second one is for Dr. Max Cole, also from Children's. I think Dr. Cole has been popping up monthly on these. And again, it's from William Prince, who says, Dr. Cole is a pleasure to work with, and I can only hope he continues on to pediatric orthopedics as he is exceptional. So thanks for your attention to the pediatric patients in the ED, Max. And the last one is for Ina Nielsen, and this is from Corey Schiffman, who noted that it sounds like on a CT scan to check the reduction of an ankle fracture, Ina was able to notice that there was minimal padding on that splint. She went back in to change the splint, and the patient actually looked like they were developing a heel ulcer, which was prevented by the actions that Dr. Nielsen took. So thank you for that, Ina. Last thing, I just want to remind everybody that we are having our banquet. It is June 24th, and we will be sending off Doctors Chawla, Hannay, Schiffman, Shin, Stansel, Taylor, Dr. Vu, and Dr. Wilkerson at our banquet. And so I'm really looking forward to seeing you all in person for that. And with that, I assume that Dr. Avrey will be introducing our grand rounds this morning.
Thank you, Dr. Chansky. Let me just share my screen here. Are you all able to see that?
Yes.
Great.
Yep.
All right. Thanks for the introduction, Dr. Chansky. My name is Avrey. I'm one of the PGY3s in the department. As Dr. Chansky mentioned, today we'll be discussing posterior wall acetabular fractures, both their outcomes and management. I'd like to thank Dr. Firoozabadi and Dr. Bain for joining me today and their help in preparation for this talk. Disclosures, I have none to report. Disclosures for Dr. Firoozabadi and Dr. Bain are listed below. For today's presentation, a brief overview. I'll get us started by reviewing some of the background information, the anatomy and pelvic osteology, as well as initial management of these injuries. Dr. Firoozabadi will then review some of his research regarding assessing stability, selecting appropriate management and outcomes. And then Dr. Bain will transition to discuss some of his translational research that's ongoing regarding heterotopic ossification, which is a common sequela of this injury that also impacts the outcomes of our patients. To provide some background information, while at our center, we see acetabular fractures quite frequently as a level 1 trauma center, and given our referral basis and catchment area, they're actually relatively rare injuries with an incidence of about 3 per 100,000 population annually. And much of the seminal work on the understanding of these fractures was led by Jude and Letournel, who in 1964 provided a case series of about 173 patients with acetabular fractures. They described the surgical management of the majority of these injuries, given the poor natural history they had observed with non-operative management. One of the major limitations at that time in guiding treatment of these injuries was that there lacked a common language to be able to classify or describe these fractures anatomically and radiographically, which their paper and subsequent refinements of it provided a framework for us to do so. Posterior wall acetabular fractures, which we'll focus on today, are one of the most frequently seen acetabular fractures, but they're not homogeneous. Even in their seminal paper, they noted some of the variations of posterior wall fractures that were seen. And it's important for treating clinicians to be able to recognize different characteristics of posterior wall fractures, as it influences both the selection of appropriate treatment outcomes, which can range from non-operative to ORAF to arthroplasty. And understanding the nuances of these fractures and their fixation may also help us to better predict long-term outcomes of the patient and provide improved patient counseling. To begin, it's useful to review the osteology of the pelvis. The innominate bone is resultant from the fusion of the ilium, ischium, and pubis, and is generally described as an inverted Y with 2 columns. The anterior column includes the anterior half of the iliac wing and is contiguous with the pelvic brim and the superior pubic ramus, and also includes the anterior articular surface of the acetabulum. The posterior column then begins at the superior aspect of the greater sciatic notch and extends inferiorly, involving the greater and lesser notches, as well as the ischial tuberosity. The articular acetabulum, which originates from the triradiate cartilage, is located between these columns of bone, and the articular regions, which include the dome and anterior and posterior wall, are components of their respective columns. Medially, where the anterior and posterior columns converge, this forms the quadrilateral plate, which is the internal cortical surface of the acetabulum. And then the columns are connected to the sacroiliac joint and the sacrum by a thick strut of bone that overlies the greater sciatic notch, which is known as the sciatic buttress. When we're analyzing acetabular fractures radiographically, there's a series of 6 main landmarks and lines that we evaluate on an AP radiograph. It's important to remember that radiographically lines are formed when the X-ray beam is tangential to a bony surface, and so not all lines have true anatomic correlates. The first line labeled here in green is the anterior wall of the acetabulum. It's typically undulating and lies medial to the posterior wall and can usually be traced medially from the superior border of the obturator foramen to its lateral margin. Next, the posterior rim of the acetabulum, which is here in maroon, represents the lateral margin of the posterior wall. And then the acetabular roof or sore seal in yellow is formed by the X-ray beam tangent to the most cranial portion of the acetabulum. In red is the iliopectineal line. This is represented, the posterior portion is formed by the X-ray beam tangent to the internal cortical surface of the sciatic buttress. And then the anterior 3/4 represents the pelvic brim. Disruption of the iliopectineal line represents fracture involvement of the anterior column. The ilioischial line, which is in blue, is formed by the X-ray beam tangent to the posterior portion of the quadrilateral surface, and disruption of this line implies involvement of the posterior column. And then finally, we have the radiographic teardrop or U, which doesn't again represent a true anatomic structure, but the lateral border is formed by the beam tangent to the inferior cotyloid fossa, and medially it's formed by a portion of the anterior quadrilateral surface in the obturator canal. In a normal AP radiograph, the teardrop and the ilioischial line should be superimposed, and disruption of this relationship implies involvement of the quadrilateral surface or rotation of the film. Judet and Letournel also recognized that the plane of the ilium and the plane of the obturator foramen were approximately 90 degrees in relation to each other, and each were about 45 degrees in relation to the frontal plane. So based on this description, they described 2 45-degree oblique views that are commonly referred to as Judet views that can also help us to better evaluate acetabular pathology. The iliac oblique view on the left is obtained by rotating the injured hemipelvis 45 degrees away from the X-ray beam, and it shows the profile of the greater and lesser sciatic notches and is best for viewing the posterior column and the anterior wall of the acetabulum. The obturator oblique view, which is obtained by rotating the injured hemipelvis 45 degrees towards the beam, we can see the profile of the anterior column as well as the profile of the posterior wall is best seen on this view. And it also allows us to detect subluxation of the femoral head. Nowadays, these specialized views we can also obtain from reconstructions from CT scans with the patient positioned supine. Based on this understanding, Judet and Letournel presented a classification system for acetabular fractures with 10 common fracture patterns divided between 2 groups of 5 elementary and associated fracture types. The elementary fractures have a singular fracture plane and separate all or part of a column. They include the anterior wall, anterior column, posterior wall, posterior column, and transverse pattern. The transverse fracture traverses both the anterior and posterior column of the acetabulum, but it's included in the elementary group because of its singular fracture plane. The 5 associated fracture patterns are then an elementary pattern with an additional fracture component or a combination of elementary patterns, and they include the posterior column and posterior wall, transverse and posterior wall, anterior column, posterior hemitransverse, T-shaped, which is a transverse fracture with an associated inferior vertical fracture line, and the associated both column in which no portion of the articular acetabulum is in continuity with the intact posterior ilium. I'll briefly review some of the relevant anatomy pertaining to posterior wall fractures. The sciatic nerve is closely associated with the posterior acetabulum, and it exits the pelvis through the greater sciatic notch and runs anterior to the piriformis and posterior to the conjoint tendon. It can be injured traumatically with posterior wall fractures, either from blunt contusion or laceration, or excessive tension from fracture displacement or dislocation. The perineal division of the sciatic nerve is the one most frequently affected, with resultant weakness of the tibial, EHL, and perineal muscles. And it can also be injured iatrogenically, so keeping the hip extended and the knee flexed at the time of surgery and careful replacement of retractors can also help reduce the risk of iatrogenic injury. The other important consideration is the aberrant anatomy that's been described with the sciatic nerve. In one cadaveric study, approximately 80% of specimens had the typically described course with the nerve exiting below the piriformis. But in another 20% of cases, there were alterations with premature divisions of the nerve or variations of the nerve passing posterior to or transecting the piriformis. And it's important to be aware of these when we're frequently approaching these posteriorly through a Kocher-Ling and Beck approach. From a vascular standpoint, the superior and inferior gluteal arteries provide blood supply to the posterior wall and are closely associated with the acetabulum in their course. So they can also be traumatically disrupted or incarcerated in fracture fragments or injured iatrogenically at the time of fixation. And additionally, the medial femoral circumflex artery, which is the main blood supply to the femoral head, is important to preserve to help reduce the incidence of AVN. This requires careful attention to the interval between the inferior gemellus and the quadratus to avoid inadvertent dissection distally into the quadratus, which may put the MFCA at risk. And then the deep branch also travels anterior to the short external rotators, so care needs to be taken and an adequate cuff left when releasing and tagging these for exposure to avoid iatrogenic injury to the vessel. Fractures of the posterior wall are frequently cited as some of the most common acetabular fractures, and in many of the larger case series I reviewed, ranging from 23 to 32% of presenting cohorts. And they most frequently result from high energy mechanisms. And one large cohort most frequently was from motor vehicle collision, followed by falls, both higher and lower energy, and pedestrian versus auto accidents. It was also important to note that there was a somewhat bimodal distribution in this study where patients age greater than 60, the most common mechanism was a fall in approximately 50% of cases, whereas in younger patients, it was more frequently the result of a high energy motor vehicle accident than 66% of cases. The posterior wall typically develops the posterior wall fracture typically develops resulting from excessive loading of the femur. In the context of a motor vehicle collision, a seated motorist has a rapid deceleration event and the flexed knee hits the dashboard, leading the flexed hip to load the posterior wall. The exact fracture pattern that then results is determined by a multitude of factors, including the position of the hip at the time of impact, the amount of force applied, and the local bone quality. When these patients first present to the ED, ATLS protocol should take precedence, especially given they're frequently associated with high energy trauma. Following that, a detailed neurovascular exam, especially with regards to sciatic nerve function, should be documented. And then posterior wall fractures can occur in isolation or with other associated acetabular fracture patterns or pelvic ring injuries. So looking for hematuria or evidence of urologic injury, making sure not to miss any open vaginal or rectal injuries is also important, as well as paying close attention to soft tissues, looking for large abrasions or presence of mural lesions, which may affect surgical approach or infection risk. There's also a very high rate of associated injuries. In one study, up to 46% of patients had an associated injury, with extremity injuries being most common, frequently ipsilateral femur, patellar, or ligamentous knee injuries. And head and thorax injuries were also quite frequently associated. In the study cited earlier, even in those patients age greater than 60 that more frequently had lower energy mechanisms, there was still a 30% rate of associated injuries. So always maintaining a high level of suspicion is important regardless of the patient's presenting mechanism. In the emergency department, one of the most urgent priorities from an orthopedic perspective is reduction if the patient is presenting with a dislocation. This is typically performed with the Alice maneuver under conscious sedation. And we should also consider the need for placing the patient in traction following reduction based on the fracture pattern and the risk of recurrent instability. Following reduction, we always obtain a CT scan. This allows us to assess the posterior wall fracture for several important characteristics, which can help determine subsequent treatment, both operative or non-operative, as well as potentially the urgency of treatment. 3D reconstructions can also be obtained to help in our understanding of fracture morphology. With a CT scan, we can look at fragment size, fragment location, the amount of displacement and congruency of the hip, looking for the presence of marginal impaction, which is depression of the osteochondral fragments into the underlying cancellous bone, as well as noting comminution, incarcerated fracture fragments, or femoral head or neck injuries. All of these factors are important to consider in then determining our treatment approach. Traditionally, surgical indications for posterior wall fractures were a lack of congruency of the hip or instability. And while congruency may be easier to assess, stability can be harder to determine. Historically, the size of the posterior wall fragment was used as a corollary for hip stability, and the size was measured based on several different methods described. The Calkins method, pictured in the bottom left, describes the ratio of intact posterior wall compared to the uninjured contralateral side, and this is based on the posterior articular surface and measured at the level of the largest fracture involvement. The Keith method measures the fragment width at the level of the fovea compared to the acetabular depth on the contralateral side at the same level. And then the Moed method is similar to the Keith method, but instead of using the level of the fovea, the measurement's made at the level of the largest involvement of the posterior wall compared to the contralateral side at the same level. The cutoffs vary somewhat between the methods, but generally speaking, it's frequently cited that less than 20% involvement of the wall was considered stable and could be managed non-operatively. Between 20 and 50% was indeterminate, and then greater than 50% was considered unstable, requiring surgical intervention. For those considered indeterminate, management was then either formulated based on surgeon evaluation of imaging and assessment of stability, or an examination under anesthesia could then be performed to more definitively determine stability. This is typically done with the patient positioned supine, the C-arm on the ipsilateral side, and then AP and obturator oblique views are frequently used. To do this, the hip is then progressively flexed, internally rotated with an axial load applied, and a positive test is considered any loss of congruency of the hip. Here's an example here in the first row with stress where the joint remains congruent and we don't see any displacement or loss of congruency. Whereas in the second row, we see an example of a positive test where you can see that the medial clear space has widened, and there's also a loss of congruency of the femoral head within the acetabulum. It's been shown that surgeon assessment of stability is unreliable, and in one study of 15 patients with isolated posterior wall fractures involving 20 to 50% of the wall, they were reviewed by 4 fellowship-trained orthopedic traumatologists that specialize in acetabular fracture care on 2 occasions. And they were asked to determine stability based on imaging and a history of dislocation, with the results of the dynamic EUA used as the gold standard for comparison. While intra-observer reliability was good, inter-observer reliability was poor, and the assessment of stability was only correct about 50% of the time. So while historically wall size has been used to assume stability, there's obvious limitations in evaluating stability based on the static imaging. The traditional approach also assumes that those less than 20% are inherently stable. But broadly performing EUAs also requires resources with anesthesia and OR time, as well as anesthetic risk for the patient. Given this, research has been done here at Harborview to assist surgeons in using additional predictors to help determine stability. And I'll hand it off to Dr. Firoozabadi now, who will be discussing these studies.
Thank you, Avery, for that excellent background and introduction and setting things up so nicely for me here. So I'm going to talk about 3 specific studies that we've done at our institution, trying to address and get some more understanding of posterior wall acetabular fractures. The first study is going to really look at other factors which we may be able to use to understand stability of acetabular fractures involving the posterior wall. The second study is really going to look at outcomes, specifically what's the rate of requiring a total hip arthroplasty after sustaining acetabular fracture with the posterior wall component. And we'll end with looking at heterotopic ossification. What are some of the risk factors and what are some options we have in regards to prophylaxis? Now, the first study was really based on this one patient from Montana. She was a 28-year-old nurse who was being treated appropriately by an outside orthopedic surgeon. She had a very small posterior wall acetabular fractures. Over the subsequent 3 months of her treatment in Montana, she had 6 recurrent dislocations and was very unstable. And by the time we were able to see her, this was a really challenging problem because it was a small wall to begin with, and now there was significant soft tissue injury to do any sort of soft tissue repair for this posterior wall acetabular fracture. And this made us start to think, is there other things we should be using besides just wall size? We knew, as Avrey mentioned, that experts in the field are not good at predicting stability. We knew from some smaller studies that wall size less than 20% can be unstable, as seen in this patient. And we know that the hip anatomy is complex with many factors. So really the purpose of this study was, is there anything else we can look at to try to clue us in on a patient that may be unstable in regards to their hip? We thought that the more coverage the femoral head had, the more likely it was going to be stable. So we wanted to look at percent femoral head coverage. We wanted to look at location that had really not been assessed before in regards to posterior wall acetabular fractures, thinking that the more cranial fracture is, the more likely it is to be unstable. And then really the osteology of the hip, for example, looking at the version of the hip, and does this matter in regards to stability? And lastly, look at a history of dislocation being a surrogate for soft tissue injury. This is a retrospective review of patients who underwent an exam under anesthesia over a 12-year period. Patients were either categorized as stable or unstable based on the EUA and the operative report, undergoing provocative maneuvers, as Avrey showed you in her portion of the talk. Radiographic assessment included a number of different ways to assess the osteology as well as the version. We wanted to look at the cranial exit point of the fracture in relationship to the dome. We wanted to look at the percent femoral head coverage. And lastly, we wanted to look at the wall fragment size based on the 3 different methods that Avrey discussed in her talk. We had 138 patients during this time period who underwent an exam under anesthesia. About 16% of these patients were unstable and 84% were stable. Again, consistent with a paper she quoted, the most common mechanism being motor vehicle collision. Now, when we looked at dislocation and head coverage, this was surprising. There was no difference in our cohort between the 2 groups in regards to having a history of dislocation as well as femoral head coverage. When we looked at different techniques for assessing osteology of the acetabulum, we also didn't see any difference between the unstable and stable groups. However, it's important to notice that there's a huge range within each of these measurements in the stable and unstable group, and our study is probably significantly underpowered to assess if osteology and specifically dispersion matter. What about cranial exit point of the fracture? We found some interesting data here in that in the unstable group, the mean distance from the fracture to the dome of the acetabulum was about 5 millimeters, and in the stable group, it was about 9.5 millimeters. And this was statistically significant. Another way of looking at this is that in the stable group, about 13.8% of the patients had a fracture that entered the dome, whereas in the unstable group, about 41% of the patients had fractures that entered the dome, suggesting that fractures that are close to the dome of the acetabulum are more likely to be unstable. Well, what about wall size? We looked at all 3 different methods for assessing wall size. We didn't find the Calkins method to be able to decipher between stable and unstable hip sockets. And more interestingly, what we found in both the Mowat and Keith method is that patients that have wall sizes less than 20% were found could be unstable. And this matches up with our patient of interest. So we wanted to kind of hone down on these patients who have very small walls and see if we find any patterns. So about 5 out of our 22 patients that were unstable had very small walls, so not uncommon in our cohort. Interestingly, 4 out of the 5 that had very cranial exit points in their fractures, and 4 out of the 5 had a history of dislocation. So potentially, while the overall cohort, we didn't see any significances in dislocation, maybe in these smaller walls, dislocation and soft tissue injury does matter. So how do we put this all together? Well, I think historically, we've really looked at wall size. And in our study, we confirmed that wall size can be helpful, but we've also shown that wall size is less than 20% can be unstable. In our study, we've shown that cranial exit point does matter. So the more cranial fracture is, the more cautious you have to be about potentially treating it non-operatively, especially in the setting of a small posterior wall. In terms of dislocation being a surrogate for soft tissue injury, again, I think this really matters for the smaller walls, potentially not for the larger walls. And lastly, I don't think we can conclude much in terms of osteology inversion from our study, because we had such a huge range in terms of numbers and had very low number of patients to really look at. So I want to shift gears a little bit and talk a little bit about outcomes of patients who have an acetabular fracture that includes the posterior wall. Outcomes are extremely variable, and I think the number one thing patients want to know in the clinic and when you're talking to them before surgery is, hey doc, what's my chance of requiring another surgery, specifically a total hip arthroplasty? And lastly, hey, if you think my chances are so high of developing a total hip arthroplasty, why don't you just do the total hip arthroplasty now? And it'd be good to have some data to support these questions. Well, there's a large number of there's a large spectrum of injury to these posterior wall acetabular fractures. Impaction can not only be challenging to address and reduce in the operating room, but it's also it's hard to maintain your reduction if you do have impaction down the line. There's femoral head cartilage lesions that we don't have much that we can offer to the patients. There's significant comminution that can occur that makes the fractures harder to treat. There can be intra-articular loose bodies, and these posterior wall acetabular fractures can occur with associated patterns. So the purpose of this study was really to identify risk factors for conversion to total hip arthroplasty in patients who had an acetabular fracture that involved the posterior wall. We thought that radiographic features of injury would correlate with outcomes, specifically the need for a total hip arthroplasty. We thought fracture reduction would affect outcomes, and we thought that these radiographic features would correlate with our reduction quality. This was a retrospective review over a 5-year period of patients. We had preoperative and postoperative CT scans as the inclusion criteria. Patients were contacted by phone that was at least 4 years out from surgery, and the primary outcome measure being conversion to total hip arthroplasty. There was 150 total patients that met our initial criteria. We were then narrowed this down to 131 patients, of which 65 patients we were able to contact by phone. The mean follow-up for these 65 patients was 7 years, with a range of 4 to 9 years. Average age in this cohort at the time of injury was 43. These were predominantly male patients, and most of the fractures are isolated posterior walls or transverse fractures with the posterior wall. Now, this is probably the most important slide of my talk today in regards to the survivorship after ORIF. You can see that at 2 years post-surgery, 5% of the patients get converted to a total hip arthroplasty. At 5 years, that number increases to 14%, and at final follow-up, at 9 years, it's about 17% of patients require total hip arthroplasty. What about patient characteristics? Well, really, not surprisingly, we found that mechanism of injury, so high energy mechanism, tend to result in higher rates of total hip arthroplasty. Fracture pattern didn't really correlate in regards to having an associated pattern versus an isolated posterior wall pattern. Time to reduction and time to surgery didn't also correlate with requiring a total hip arthroplasty. What about the radiographic findings? We specifically looked at dislocation, wall comminution, intra-articular debris, acetabular impaction, femoral head lesions. In isolation, while there's a higher trend to requiring total hip arthroplasty, each of these was not statistically significant. However, when you start combining these findings, what you see is that they have all 5 features, then they have a 50% rate of requiring a total hip arthroplasty, and we term these severe injuries. And that's a significant number if you have all 5 of these characteristics. What about reduction quality? We spend a lot of time reducing these fractures and trying to get them right. Does that matter? Do we need to be this good at getting an anatomic reduction? Does it matter? Well, in this study, if your reduction was within 1 millimeter of being anatomic, your annual rate of requiring a total hip arthroplasty was 0%. When your reduction was between 1 and 4 millimeters on the postoperative CT scan, the annual rate of total hip arthroplasty was about 1.4%. And this significantly jumped once the reduction was off more than 4 millimeters to 10.6%, requiring a total hip arthroplasty on an annual basis. So reduction does seem to matter. In terms of age, what we found is if you're older than 47 years old at the time of injury, your conversion rate was significantly greater than if you were younger than 47. Those severe injuries that had those 5 characteristics tended to have worse reductions. In the whole cohort, when the reduction was off more than 4 millimeters, 60% of these patients had those severe injuries. And in the rest of the cohort, it was about 13% and less severe injuries. And we didn't find any functional outcome differences if patients required a total hip arthroplasty versus the patients that didn't get a total hip arthroplasty using the SF8. What are some other studies that have looked at this in regards to posterior wall acetabular fractures and outcomes and conversion rate to total hip arthroplasty? Really, the MOAD study and the Creeder study are the most commonly cited studies. And what you'll notice is that their total hip arthroplasty rate is significantly lower than what we reported. However, when you look at their mean follow-up rate and minimum follow-up rate, it's significantly less than the follow-up time point that we used, which was a mean of 7 years, and theirs is a mean of 3 and 4 years. Furthermore, when they looked at reduction qualities, they didn't use CT scan and they used X-rays, and they found that a gap more than 10 millimeters was significant for requiring a total hip arthroplasty, whereas we really looked at it on a millimeter level. So where does this put us? Well, it seems that though that these factors that go into having a posterior wall acetabular fracture can affect outcomes and result in higher rates of total hip arthroplasty. Furthermore, having these factors makes the reduction significantly more challenging. And while we try to obtain an anatomic reduction, potentially when they have all these 5 factors, we're not very good at obtaining an anatomic reduction, or we simply can't. And this leads to a higher rate of total hip arthroplasty. Now, there's a number of other things that relate to outcomes and influence outcomes. And the last thing I want to focus on is really heterotopic ossification. As many of you know in your own subspecialties, heterotopic ossification around the elbow, the knee, the hip, as well as around amputation sites can cause significant pain. It can limit patients' range of motion and ultimately result in a poor quality of life. Risk factors can really be broken down into 3 categories. There can be soft tissue factors, they can be clinical and systemic factors, and then there's the surgical factors or the surgical insult. If we take a look at soft tissue factors, a study done by Dr. Rout as a senior author a while back here at Harborview, they noted that the gluteus minimus appears necrotic and unhealthy in patients with a posteriorly based approach for the acetabulum. And when debridement of the gluteus minimus was performed, there was a significant decrease in rates of HO. So that being a soft tissue surrogate potentially for developing heterotopic ossification. There's a number of small series studies that have looked at a number of other things that can increase your rate of HO. Probably the most commonly cited is traumatic brain injury followed by thoracoabdominal trauma. But there's a number of other things such as femoral head injury, ipsilateral femur fractures, and then injury severity scores in patients who have knee and hip surgeries after trauma. In terms of surgical factors, really the choice of exposure relates to the rate of HO. Now, this can be not only from the surgical insult, but the fact that the larger exposures, such as the iliofemoral approach, tend to be worse injuries and worse soft tissue injuries that require that broad-based of an approach. The iliofemoral is the highest in regards to developing HO, followed by the Coker-Langenbach, and followed by the ilioinguinal. And then dual exposures, as well as the need for trochanteric osteotomy, have been shown in small series to increase rates of HO. The purpose of our study was really try to add some data with larger numbers to this area to determine risk factors for developing HO in patients who were treated with a posteriorly based Coker-Langenbach approach. This was a retrospective review of data that we had here. It occurred over a 10-year period. Inclusion criteria was really any patient that had a Coker-Langenbach approach for a acetabular fractures. Patients were excluded if for any reason they were on indomethacin. This was a set protocol with most patients receiving the same type of approach and exposure with debridement of the gluteus minimus up to the superior gluteal neurovascular bundle and be made toe touch weight bearing for 6 weeks after surgery. Initially, we scanned through 1,159 patients, of which about 56% of them had a Coker-Langenbach approach. The described protocol was followed in about 78% of those patients. 10% of them got HO prophylaxis with indomethacin. And after exclusion criteria, we were able to identify 312 patients to study. There was mainly posterior wall acetabular fractures as well as transverse with posterior wall acetabular fractures in regards to fracture pattern, which is not surprising given the approach we used to study. 38 patients developed what we would consider severe modified Booker classification, class 3 or 4 HO. When we looked at these patients compared to the rest of the cohort, what we found was that extended intubation, specifically patients that were intubated for more than 72 hours, had a significantly higher rate of heterotopic ossification. Now, what do we do with this? We know that there's a number of factors that can increase your rate of heterotopic ossification. Many of these factors we can identify preoperatively. So what do we have for prophylaxis for patients if we think they're going to be at high risk for heterotopic ossification? Well, prophylaxis really comes in two forms. There's focal radiation, which is not available at many centers and extremely costly. And there's high-dose anti-inflammatories that can be used. In regards to the high-dose anti-inflammatories, there's a concern for delaying union or non-union, and they do have a significant side effect profile. So what are the take-home points from this portion of the talks? Well, if there's anything, small walls can be unstable, especially if they're cranial and are associated with the dislocation. The location of the wall does matter. Reduction is very important when fixing these fractures and trying to obtain an anatomic reduction. Roughly, when counseling patients, you could tell them that there's a 14% chance of needing a hip replacement by 5 years. Risk factor, an additional risk factor identified as being intubated for more than 72 hours. And current HO prophylaxis options are costly and have side effects. And this is where I want to introduce Dr. Bain, who's one of our basic science colleagues, who's working on some really exciting research to try to help us potentially prevent heterotopic ossification. Thank you.
Thank you, Reza. Grateful for this opportunity to share the work of our laboratory as it relates to heterotopic ossification. As many of you know, our laboratory has long focused on mechanotransduction and the ways in which muscle and bone interact during skeletal adaptation and repair. Given that background and context, the story I want to share reflects how the pursuit of basic science question can lead to a novel observation, which in this case has been the catalyst for an idea that is now on its path to clinical translation. Specifically, we set out to explore how the skeleton's loading environment might influence the response to a bone injury. To do this, we developed what we call a pseudo-fracture model, which is created by this unicortical defect in the tibia, which during the process of repair recapitulates normal fracture healing up to and including the periosteal osteogenesis, intramembranous bone formation that you can see proximal and distal to the injury site in this animated CT image. As skeletal injuries are often accompanied by disuse, we set out to pair this model with our model of transient muscle paralysis, which we achieved by the intramuscular injection with botulinum toxin A, a neuromuscular inhibitor. The results from this experiment were far more dramatic than even we had anticipated, because when we paralyzed the muscle, we found that over 90% of the callus had been inhibited. But the other thing we didn't anticipate was that the bone would in fact heal despite the absence of callus, and that even direct injection of botulinum toxin into the defect site had no effect on bone healing. Further, as we and others have now shown, calf paralysis only modestly affects the mechanical strains seen in the hind limb during mechanotransduction, which to us meant that we could no longer attribute the muted response to disuse. Instead, we reasoned that the osteogenic inhibition must be arising via either direct or indirect effects of Botox on muscle and/or the neuromuscular signaling. These observations, when coupled with information in the literature, caused us to speculate that Botox-induced inhibition of neuromuscular signaling might have potential to prevent trauma-induced heterotopic ossification. Once we posed this question, we set out to answer it in an established model that develops HO lesions following intramuscular injections of bone morphogenetic protein. Following the BMP injections, Botox can be administered at the injected site. And then, as you can see from these animated micro CT images of the tibia in this case, you can see the outline of the muscle in white, and you can see the HO lesion in orange. These findings demonstrated that the inhibition of neuromuscular signaling and/or the muscle paralysis was responsible for mitigating HO. But of course, Botox is a multi-billion-dollar pharmaceutical because it causes muscle paralysis. So how could we determine if Botox inhibition was independent from its effects on muscle paralysis? Well, given the size of the mouse calf muscle, probing this question was really a challenging task, but Brandon Osk in our group devised a clever experiment to test this thesis. What we decided to do was use a stereotaxic delivery system to inject Botox in two different locations. One of the injections located at the site of the BMP implantation, and the other at a site remote to the BMP implantation. The results from this study provided very convincing data that the targeted Botox was actually required for the mitigation of HO, as muscle paralysis in and of itself did not blunt the HO formation. Well, if targeted delivery was important, what other parameters might we manipulate to optimize this therapeutic approach? Well, the natural progression of our studies are really depicted here, because we wanted to consider whether or not the effects of Botox were dose dependent, because after all, muscle paralysis did not appear to be the driver of efficacy, and also dose distribution. That is, could we parse out the doses into smaller increments and distribute them over larger areas to protect against the formation of heterotopic bone? Again, very challenging to do in the mouse model, but when we did these studies, it was clear that one, yes, there is at least some dose-dependent effects, as a 0.5 unit dose of Botox is superior to 0.1 units of Botox, and that dividing a 0.5 unit dose into two 0.25 unit doses appeared to increase the ability to inhibit HO. More critically, this minor variation using distributed dosing revealed the potential to reduce off-target effects on muscle, for example, the atrophy that occurs, as well as the potential to produce osteopenia in adjacent bones. Either way, when these preclinical findings, if we start to scale them to human use, the doses that we're using are an order of magnitude lower than what has already been safely used for orthopedic applications, such as in distraction osteogenesis or total hip arthroplasty. Taken together, these observations form the basis for IP disclosure and a technology patent by the UW for a medical device system to inhibit HO following orthopedic trauma. Subsequent to this patent application, The technology was licensed by a Seattle-based startup, In Situ Therapeutics, and the project is now moving forward in collaboration with In Situ Therapeutics to advance the technology into a model system that more closely resembles HO in human patients. The collaboration with In Situ allowed us to secure an NIH technology transfer grant to fund proof of concept studies in a rabbit model that mimics trauma-induced heterotopic ossification. The grant actually had two different components. There was an engineering component, which involved developing a template that would allow us to distribute doses in a region of interest. And then also a treatment component, which would allow us to compare treated and untreated animals. Briefly, what you see here on the left is the template, which is actually a series of stacked, interlocking 3D printed guides that enable us to locate 15 micro injections of 30 microliters each into a region of interest. The other piece of the engineering component was to actually use visopaque dyes to demonstrate that we could provide coverage to this region of interest, because obviously heterotopic ossification is a three-dimensional lesion. The rabbit model itself, in order to create the heterotopic ossification, we enter the greater trochanter of the femur. We ream the femur, harvest bone debris, and then distribute that debris into the surgical field, into that region of interest. Once the debris has been placed, the muscle incisions are closed, and the template is aligned on the muscle surface using a intermedullary pin and then suture anchors. And then very quickly, we can use a pump-driven syringe system to deliver the Botox to this region. So once we were able to demonstrate our ability to deliver and to distribute the drug to this region of interest, we completed a series of animals comparing rabbits treated with Botox and untreated rabbits, and the results are shown here. Again, the model and the 3D distribution, and the quantification of HO within the targeted volumes demonstrated that we could inhibit over 90% of the formation of HO in our region of interest, which was even better than we had even anticipated. In our discussions with orthopedic surgeons, it's really a matter of shielding an area and preventing joint ankylosis, which is really important. So our goal was to inhibit at least 50%. And in the analysis, we were also able to demonstrate that if we expanded the region of interest, in other words, was there protection outside of the area of coverage? The answer to that was also yes. When we looked across our entire data set, we were able to determine that the volume resulted in a significant increase in that protected region. Importantly, we saw no effects on defect healing. So this project is now moving forward for a phase 2 STTR application, which will enable us to compare this approach with current standards of care. And we're obviously very excited to move this project forward to the next stage. With that, I would just close by acknowledging our collaborators and our funding sources.
Great. Dr. Chansky had to step away, so he asked me to help field any questions that anyone has. That was 3 great talks. Okay, great. Dr. Novak, you did a great presentation. Tell me where you think this goes next with evaluating hip stability and relating it to age as well. So let's take 2 patients. Take a young patient with dysmorphic acetabulum or proximal femoral version. How do you want to think about that in terms of their overall hip stability? Oh, you're still muted there, Avrey. Sorry.
Thanks. Yeah, so I guess if they're presenting in the context of dysmorphism and maybe they have less coverage to begin with, or their version is different, may put them more at risk for kind of recurrent dislocation. So I think my threshold might be lower in that context, or at least lower to at least take it for an EUA to determine.
You still consider the EUA as the gold standard of your clinical decision making?
I think I'd still have a relatively low threshold to use an EUA, just because I think all the other factors are still relevant and important for decision making and kind of help us form a big picture. But I think at this point in time, for those that are more borderline, I would still do an examination under anesthesia to kind of more definitively determine.
Great.
Especially in younger patients.
Question for Dr. Firoozabadi, whatever happened with the index patient that you showed?
Yeah, it's a really good question. She required 2 main surgeries. The first one failed and she kept continuing to dislocate. The second one, we had to put significant restrictions on her. So basically no hip flexion, and kept her in traction for an extended period. And everything at that point socked in. But it's challenging to put a patient, especially an adult patient, in that kind of position and not let them mobilize like you'd want them to mobilize.
And Dr. Bain, how soon are we till using something like this in humans?
I was afraid someone would ask that question. I think the next phase for us is to move the project to GLP studies in an animal model. And then once those GLP studies have been completed, we can build on the current safety data that is out there for Botox, which has demonstrated that at the appropriate doses, it's quite safe. And so depending on funding for in situ therapeutics, I think we could see this move into humans sometime within the next 3 to 5 years.
Great. Very exciting stuff. All right, unless there's any other questions, thank once again the 3 speakers today did an excellent job, and see everybody around.